Welcome everyone to this new PULM talk. We will start with Dr. Wenhai Sun with the first talk for today. Okay, Dr. Derek is helping Dr. Sun. Maybe you can share from your computer if you are together. Do you want to try that option from Derek's computer?
Can you hear me?
Yeah, great.
Okay, Dr. Sun is dealing with his microphone. His computer is something happened. Maybe please wait a moment. He's
Okay.
reload again. Please wait a moment. Thank you.
It doesn't matter. We are okay.
I'm Derek. I'm Dr. Derek. I'm Dr. Sun's junior doctor. I will be the translator for him tonight.
Great.
Thank you.
Welcome.
And he's loading in the meeting. Is it morning in your country right now?
In mine, in Argentina, yes, it's 8 a.m. That's why my face. Derek, maybe you can try to share the PowerPoint of Dr. Sun from your computer.
Yes.
Could be that possible. If not,
你可以用把那个你不行，你吧，你得那个。
Okay, now we can see the Derek's screen. It's okay.
Okay. Can you hear me?
Yes, we hear perfect.
Okay.
You can put it. You can put it in full screen.
稍一等，
你用我这个电脑，直接用我这个电脑，
没这个。
你用我这个吧。
好，我们先来。
你来问一下能不能听得到，应该可以的。
Hello, can you hear me?
Yeah, it's perfect.
Okay.
Welcome.
我们先讲。
啊，你再给我讲。
Let's start.
Yes, please.
Good evening, everyone. I'm Dr. Sun from China, and I'm very grateful for the opportunity to share my experience in treating macrodactyly over recent years. My specialization lies in hand and foot surgery, as well as microsurgery. Here are the two hospitals I have worked for. The hand and foot surgery department of the Shandong Provincial Hospital is among the best globally for microsurgical techniques. I worked there for 15 years under the leadership of Professor Wang Zhengtao. I have performed more than 300 thumb and finger reconstruction surgeries at Shandong Provincial Hospital. Microsurgical technique from the foundation of my deep work on macrodactyly concepts such as layered microsurgical anatomy, a holistic approach, and the pursuit of perfect reconstruction are all deeply influenced by the philosophy of finger aesthetic reconstruction. I now work at the Department of Plastic and Reconstructive Surgery at Shanghai Nice People's Hospital, where my department ranks first 10 consecutive years in China. My current focus is on hand and foot deformities and microsurgical reconstruction, while also managing emergency replantation cases in my department. Treating macrodactyly is extremely challenging and remains a significant difficulty faced by hand and foot surgeons. To save time, I will skip the discussion on diagnosis and classification. The current situation is that complex and severe macrodactyly is prone to recurrence and often require finger and toe amputation with multiple surgeries, frequently yielding unsatisfactory results. What can we do to improve the surgical treatment of macrodactyly? These are some cases I performed in the early years. Case 1. This was a severe case of macrodactyly involving the thumb, index, and middle finger. At that time, I had few experience, so regretfully, all three fingers were amputated. Thinking back now, at least the thumb should have been perceived and corrected. The experience from this case is that a thin flap raised from the dorsal side of the first web space seemed to allow for thorough excision of the overgrowing tissue. This was my second case placidation of index. After placidation of index finger, I raised the thin flap, excised the fat, infiltrated thinner muscles, and radial digital nerve, fused and shortened the first MP joint, resulting in thorough debulking. The sum got us close to normal appearance after surgery. Follow-up after 11 years showed no recurrence. This surgery was similar to case 2. After 10 years of follow-up, the condition remains stable. In this case, even immediately post-surgery, the affected area was still significantly bulky. The debulking was partial rather than complete, and this was ineffective and at controlling overgrowth. Thinking back now, fat tissue and muscle should have been thoroughly removed, and the joint should have been fused and shortened. A valuable experience was that we recognized the importance of the raising thin flap with subcutaneous artery branches. In the early years, partial amputation of toes and all preservation without reduction often failed to achieve the desired aesthetic and functional outcomes. These are some post-operative cases that undertook partial debulking and amputations. The results were not satisfactory. Since then, we have started to think how to optimize surgical techniques to improve the appearance and function of the overgrowing finger, how to reduce recurrence rate, and how to minimize the number of surgeries. The core challenge is achieving effective debulking, which is also the most difficult problem. Our experience is thorough microsurgical debulking to full extent, striving for a more normal hand and foot appearance. Proactively addressing bone and the joints. So, how can we achieve thorough microsurgical debulking? First, we need to know the features of the overgrowing tissue. Bulky tissue distribution difference and tissue proliferative potential difference. We need to know layered and thin flaps. Giant fingers and toes can be dissected to get thin, reliable flaps containing superficial with shallow fat tissue, digital arteries with branches, and digital nerves within the branches. How to do a debulking procedure? With or without clear anatomical layers, this process can be described by peeling a radish instead of biting an apple. This video shows how we make microsurgical debulking and osteotomy for giant fingers. This video shows how we make a microsurgical debulking at the palmar side of the hand. The specific details in handling tissues. We must admit that re-amputation is still an alternative method for the surgical treatment to macrodactyly or foot. For me, the considerations for finger or toe amputation are as follows. Then I'll show you some cases of mine over the past 5 years. Comprehensive clinical data will be included in my forthcoming publication and are not presented here. This is a patient with macrodactyly of the second toe. The patient strongly requested to preserve the overgrowth toe. Complete microsurgical debulking and IP joint fusion were performed. Appearance and function of the foot was good 1 year after surgery. This is another patient with macrodactyly of the second toe. The outcome of the surgery was satisfactory to the parents. This patient had isolated macrodactyly of the single large toe. After completing microsurgical debulking and IP joint fusion, the appearance was satisfactory. This patient had a macrodactyly of both the big toe and the second toe. 2 years post-operatively, the appearance and the function was good. This patient had macrodactyly of both the big and the second toe. Both preserved complete microsurgical debulking and IP joint fusion were performed with a toenail flap that preserved only the vascular and the nerve connection on the second toe. 3 years after surgery, there was no significant hypertrophy, and the appearance and the function were good. This patient had severe macrodactyly of both the first and second toe. Complete microsurgical debulking and IP joint fusion were performed. We had got 2 near normal sized toes after surgery. But the first toe showed inward deviation 1 year after the surgery. It can be easily corrected. 2 years later, the skin texture was almost normal. This patient had severe macrodactyly of the first, second, and third toe with significant hypertrophy of both the dorsal and plantar aspect of the foot. The giant second toe were amputated. We preserved the other 4 toes. The dissection of the dorsal pedicle flap clearly showed the pedicle vessel. This patient has severe macrodactyly of the first, second, third, and 4 toes. The 6 toes were amputated. We had preserved 4 toes with complete microsurgical debulking and IP joint fusion. The appearance of the foot was good. So was his walking function. The first surgery for this patient was performed at another hospital, but it failed to achieve complete debulking, leaving the appearance unsatisfactory. We performed a second surgery with thorough debulking. Before surgery, this patient had severe stiffness and bone overgrowth of the metatarsophalangeal joints. Hypertrophic bone was cleaned and the joint was filled. In this case, despite MP joint failure, there was no significant impairment in walking. In case of macrodactyly or hand, the primary issue are bony joint and neural hypertrophy. Ideal result can be achieved by preserving a thin knee flap while retaining the finger. This patient had macrodactyly of the index and the middle fingers. Despite 2 surgeries at another hospital, the finger remained hypertrophic. During our surgery, complete microsurgical debulking and corrective osteotomy were performed 5 years after the surgery. There was no significant regrowth. PAP reconstruction surgery is planned soon. Frankly speaking, debulking and osteotomy is just to help us preserve a stiff finger because the PAP joint and GIP joint still can't move. Is preserving a stiff finger meaningful? Our answer is yes. This patient has severe macrodactyly of the middle and the ring fingers with thickness exceeding that of adult finger and almost complete loss of joint mobility. Complete debulking excision of hypertrophic digital nerves and IP joint fusion with phalangeal nerving were performed. At the 1 year follow-up after surgery, the appearance was satisfactory and MP joint function was restored. The patient is considering secondary joint transplantation surgery to reconstruct flexion and extension of the PIP joint. This patient had a macrodactyly of the index and the middle fingers. Complete macrosurgical debulking was performed. The middle finger and went IP joint reduction and fusion, while the index finger being less severe, only required the DIP joint fusion. This patient had a partial amputation in another hospital. The incomplete debulking of the finger resulted in ugly appearance. So we reshaped the index finger and debulking extra tissues. This slide shows a patient who underwent some debulking and osteotomy. The main complication of this surgery include recurrence, neobed and skin necrosis, bone union and scar contracture. We calculated the the exact number of the patients experience them certain complications. We have put forward this staged approach to treat macrodactyly, and the core techniques are posted here. That's it for your attention. Thank you.
Impressive, Dr. Wenhai. So let's see. Please leave your questions in the chat. Andres, do you direct the thing?
Okay, yes, thank you. First, it was very interesting, all the pictures and videos with your amazing cases. You said it in the talk, but it's always difficult to know how do you deal with which neurovascular bundle do you preserve and which one do you resect?
什么情况下接，什么时候保？你讲就行没事，我给你翻译。
前面有。
So the question is, how do you decide to preserve a figure or give an amputation, right?
No, not amputation. The neurovascular bundle, the digital nerve and the vessels. When you have both sides involved, the radial side and the ulnar side, how do you decide which one you resect and which one you preserve?
Okay, fine. We have dealt with a lot of nerves during the surgery for the patient with macrodactyly. Typically, all of us know that the finger was innervated by two digit nerves, right? And generally, in such macrodactyly patients, one side of the nerve is overgrown, obviously, and the other side is try to be close to normal. So in such a situation, we try to resect the overgrown nerves and preserve the other side. So, as Dr. Sun said, we designed a very big, thin flap, right? And this flap was innervated by two nerves. We resect one side of the nerve and preserve the other side, the nerve and the skin. And this flap can be innervated by the preserved nerves. And after a long time follow-up, we find that the sensation of the fingers after the surgery is satisfactory. And as you mentioned about the artery and the veins, and it depends. If you can dissect the both sides of the vessels, you can preserve them more. But in some situation, especially if the patients have already took a surgery before, you have no method to preserve all the arteries and the veins together. So we preserve the one side of the vessels to secure the blood supply of the fingers. Thank you.
Great. We have some questions in the chat. Here it says, let me read. Is the termination of the PIK3CA in the biopsy important?
Yeah, okay. The macrodactyly, this disease is related to this gene mutation. Yes, we can do a biopsy, but based on the biopsy result, we just get an exact diagnosis of this disease. We can say, yes, you are a macrodactyly patient, right? But this just will help us to decide whether we can give some like some medicines like rapamycin to control the overgrowth of the fingers or the toes. But from our experience, for patients with very severe macrodactyly, especially for patients with a very young age, the complication, when we say the complication of the medicine is very bad. Maybe they cannot bear the strong effect of the rapamycin. So we don't like to give a little baby some medicines like rapamycin to control growth. We prefer to do thorough debulking and sometimes osteotomy to decrease the size of the fingers. And when the baby grew older, maybe 6 or 7 years later, he was strong enough to bear the complications of the medicines. Maybe we will give him or her some medicines to control the later overgrowth of the tissues. But it depends. And we have led several clinical trials to make sure that this method works, but we don't know. The follow-up is not in. We need time to make it sure. Thank you.
Great. We have a question from Federico Canavese that says, how do you design the flaps for the pulp and nail in the tip of the finger?
How to deal with the fingertip, right?
Yes. How do you design the flap for the pulp and the nail in the tip of the finger? Yes.
Yes. For both of us, we both, when we do the surgery, we use the microscope. We use the microscope all the time during the surgery to make sure we dissected all the nerves and arteries of the fingers. When we get close to the fingertip, we need to find the branch of from the artery to get into the fingertip and get into the nail. And we preserve this little branch and then we remove the other tissues and to reshape the fingertip. And this is in a word, this part is very difficult. It's not easy to deal with. And before we didn't use the microscope to do the surgery because we think it's a waste of time. But the truth is, if you use a microscope and it will how to say, it's helpful. It's helpful to find that branch. Thank you.
So Derek, so you use the microscope to dissect the bundles, and in order to resect all this tissue, that it's like a tumor. If you don't take all this tumor, it will regrowth.
Yes.
So it's like a kind of tumor surgery.
We need to mention a very important thing, that is the whole procedure of the surgery is a little bit different from the cancer surgeries, because for a cancer, the boundary between the normal tissues and abnormal tissues is not very clear. But from our experience and our anatomy research, we find that there's a space between the skin and the overgrown fat tissues. This is very important. When you cut off the skin and we find the space between two tissues, and it's the very important method. The thing is to find the artery. But in such a patients, the artery may be buried into the overgrown tissues. Yes, if you don't want to use the microscope, you need to make sure that you will not injure the artery. I think it's not easy to protect the very thin arteries and the veins. So we prefer to use the microscope. it's very useful. And
Okay.
we can through this piece, and we dissected deep to the sheath of the tendon, and use this space. We can remove the whole affected tissues at one time. I don't know whether I make you understand what I said. Sorry.
No, we do. Thank you, we do. So do you use also the microscope to separate the skin to the overgrowth tissue, to differentiate normal tissues? Do you use also the microscope to separate skin from the fat, from the abnormal fat?
Yes. Because when you cut the skin, we need to preserve the artery web. We say maybe the vascular the artery behind the dermis, right? We try to preserve all the branches we can see during the surgery to make sure the blood supply over the thin flap, because it's very thin, and
Okay.
at the very early time, we are typically not sure whether this thin flap can survive after the surgery. And from these patients year by year, we are very confident to say that through this space between these two layers, to preserve the artery behind the skin, and after the surgery, the blood is good. Don't worry about the blood, it's good.
Okay, great. So is a technical tip not exsanguinating? No, do you do exsanguination before surgery, or you avoid exsanguination? The smart, do you use this smart band or not before surgery?
Okay, do you use the Microsurgical as capitation and replace after? No, we have not do such a surgery for now, because
Okay.
the main purpose of this surgery was to preserve the fingers or the toes for a baby, for a young patients, and in some
Sorry, Derek.
cases,
No, Derek, sorry. No, the question is that if you do exsanguination, if you do
transfer to the hand, right?
before surgery, the band, you don't use the band, no? So,
You
the
need a
smart
band
band.
to. No, no,
No,
you
okay.
can't use it. You can
Never
use it.
mind.
Yeah, if you use
Okay,
it,
never mind.
it's not easy to find the artery. Yeah.
Okay. So thank you very much. It's been an honor. Thank you, Dr. Wei Sun. Derek, thank you very much. I hope we meet in the future. And I think we have to move to the next talk. Thank you very much.
Thank you.
Thank you.
Can you stop sharing?
Okay. 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 I've already stopped it.
Okay,
You are mute right now.
mute. Yeah, no.
You are mute.
See. Sorry. So I came with this is a much easier procedure, but I think the worthy thing is the idea, no, of creating forearm fusion in a low cost way, which is taking advantage of the biology and using the periosteum. So you know that supination deformity is common. It's almost 10% in extended herbs, and almost a quarter of the patients with complete palsies. So when you have a complete pronation palsy, to me the indication is to do a one bone forearm, and I use the technique described by Scott Kozin. I will share the papers, because of my, let's say, my history with the periosteal flaps, I came with the idea of doing a low-cost procedure. You don't need a plate, screws. You just take a tongue of periosteum from the ulna. You connect it to the radius, and you get a less invasive and less cost procedure. This is the idea. And before going on, I want to remind you that in November we will do in La Habana our second course on obstetric plexus palsy injuries. This time it will be about secondary procedures, and there will be it's a live course. In the first day, we will examine patients, and the second and third day we will do live surgeries, and most of the best experts in the world will be there. So first course was wonderful. This one will be even better. So periosteum in children is thick, easy to harvest, and this is the organ for bone repair, right? And it has adult bone stem cells in the cambial layer. So it's really powerful because it's a carrier of osteogenic stem cells, leading to a really fast consolidation. I suggest you to read this paper. And one of the flaps we use is the periosteal flap from the ulna. The anatomy is the same as the posterior interosseous skin flap, right? And I use it for the radius non-union. Also, you can use it for carpals or metacarpal problems, and for proximal ulnar non-union. So, and this is just a case to show you how previously septic, infected, multi-operated radius non-union can be treated with this flap. You see the 2 centimeters gap, and how we solve it. So just by using the periosteum, but not doing a flap, just taking a tongue of periosteum, we can get forearm fusion. And before going on, I want to show you some of a little bit the anatomy. This is these slides are from my periosteal flap cadaver course. So just reminding you the anatomy. So incision is the same as the skin flap, right? So the septum is in a line between the lateral epicondyle and the dorsal, the distal radio-ulnar joint. So you have to look for the septum between the extensor digiti minimi and extensor capitularis. You find the septum. Here you have the septum, EDQ, ECU, the septum. And the vessel, you will see, so this is the ECU, EDQ, and the septum that you have to preserve with the vessel. And you can see the vessel from the radial side. You see? The vessel is in the radial side. So you have to keep the septum and then get the periosteum with the septum. This is the connection to the anterior interosseous vessels. This is another video showing sexocapitularis, the periosteum of the ulna, the ADM, the index proprius, and the interosseous membrane. The septum, and I will show you the interosseous membrane, because if there is some stiffness, you have to release the interosseous membrane. If there is more stiffness, you have to release the posterior ligaments of the DRUJ. And here I'm releasing the septa that separates the ECU to the FCU, and we really just take periosteum as a tongue. No, we don't do really a flap. So you take a tongue of periosteum and you put it towards the radius, no? And this is some images. So in the image of the right, you have the periosteal flap, and you see I have cut the interosseous membrane, and I preserve, because you open the interosseous membrane, you see the anterior interosseous vessels that you have to preserve, and then you move to the radius. Here you can see the septum. The periosteum has been elevated as a tongue. Then you elevate the extensor muscles to get into the radius, in which you cut the periosteum, and you suture periosteum with periosteum to periosteum. You fix the forearm in around 20 degrees of pronation, and this is an example of supination deformity, and how you get this callus. As I said, the position is around 20 degrees pronation. And then an interesting thing is that you see hands that looks that they have really that looks like a very poor function, but you put these patients in a 20 degrees, around 20 degrees of pronation position, and over time they get better function. Maybe it is because of the contact, because of the using of the hand. Some cortical areas will recover, and you get an improvement of the function, and it has been published in several papers. This is just one example of supination deformity. Passive supination 100 or 110, pronation -30. This is a hand that has not been used, a very poor hand, but you put it in pronation, and they improve a lot the function. And then you see, this is the series I sent to a journal. You see that I do it in very young patients. At the age of 2 years, I do it. Why? Because I want to put the hand in a functional and, let's say, relationship position, because otherwise you will have, during the whole childhood, we have the supination recurrence and problem if you try to do osteotomies. So this is one thing I wanted to comment. And the other thing I wanted to comment is in older children, sometimes you have to release not only the interosseous membrane, but the posterior capsule of the DRUJ. And two of the patients in which I proposed this technique, I had to move to a one bone forearm. So those that are rigid more than -60 degrees pronation, maybe you need a one bone forearm. And you see here, this is a complete palsy. This is supple, completely supple. If you do here a bicep rerouting, you will have a pronation deformity, which is also bad. So I think that you finish the problem, end the problem, doing this fusion. And the thing I don't like is the incision. Is just a cosmetic thing. Exactly. That's why now I moved from the ulnar flap to the radial flap, radial periosteal flap, which is based in the anterior interosseous vessels. It's the same, but from the volar side, and the scar is much better, but the procedure is the same. Is very similar. The steps are very similar, and just showing you a flap periosteal, radial periosteal flap for a ulnar non-union. You see here the harvested periosteal flap that will be tunneled and bring to the ulna and brought to the ulna. And then how you get the consolidation. This is not the same thing, no? So we are doing is not a flap, it's just like a tongue, but just to give you an idea that periosteal flaps are wonderful. And again, reminding you the course in La Habana in November. You can text me by Instagram to Dr. Soldado or by email. And thank you very much.
Thank you, Dr. Soldado. It was a great talk. We made some of these cases together, and it works wonderful. Maybe I think it's good to if you can talk about the postoperative care. How do you manage? How many time with the pin and with the cast?
So the periosteum is really powerful, and you get union really fast. So I keep the wire. I keep it 4 weeks. But for a younger child, let's say 2 years, you can keep it for 3 weeks.
Great. So in general, you consider that for brachial plexus with a complete brachial plexus that don't have good motion of the pronation and supination, you fix it in that position. That's the indication of this technique.
So the indication is complete pronation palsy. So the patient has no active motion. If the patient has some active pronation, then I go to the bone. I go osteotomies. No, I do percutaneous osteotomies if they are young. If they are older, I do osteotomies and plating. But if there is a complete pronation palsy, you have two options. Doing a fusion and forgetting the problem, or doing a biceps rerouting. But for me, the biceps, I left the biceps rerouting because if the forearm is supple, you will get, or the patient is young, you will get a pronation deformity, which is all as bad as the supination deformity. And then other problems are that maybe you lose elbow flexion strength. It can happen. The scar is really ugly, and anyway you lose the supination in most of the cases. So I think it's more precise. You can get the more precise position doing the fusion.
Great, thank you. If you have any question, you can write it down in the chat box and we can read it.
In the meantime, I'm going to share some papers, some docs. In the chat, I can share in the chat, right?
Yes.
File. Here it is. I shared the one bone forearm technique from Philadelphia, Philly, and some other papers.
Thank you. Downloading.
Okay, so if there are no more questions, I think we can stop here. I don't know what happened with Dr. Kozin. We will know later. But amazing, no, that what Dr. Wei Sun can do with the Macrodactyly. I think that the only way to learn it is to see it, to go there. You know, they are really, they know very well the vascular anatomy of the fingers and toes. They know how to find the branch to the nail, etc. So that's the clue, and the only way to learn this is to visit them, to see them doing this technique. Otherwise, yeah, I think it's impossible to by explaining. It's impossible to learn how they do it. But very interesting, very interesting. It has been really very interesting. Very interesting. Okay, so see you next second Sunday in July. I guess we will be more people. Ciao.
Thank you, everyone. See you.
I will leave for a few minutes it on, just if you want to download the papers.
Recording stopped.